Welcome to Let's Talk Antigonish, the podcast where we sit down with neighbors, experts, and friends to explore the stories, the questions, and the big little issues that shape life in our town, one conversation at a time. This week, we sat down with our local MLA, Michelle Thompson, to ask her about her life as an MLA, but also to ask her a few questions about healthcare in Nova Scotia. Hello and welcome to Let's Talk Antigonish.
This is Anuj.
And this is Justin, and we welcome today the Honourable Michelle Thompson, Minister of Health and Wellness.
Hi, folks.
Hello. You also have other titles in your job as minister.
Yes, I do. I have a couple of other responsibilities. So I am the minister responsible for the Office of Healthcare Professional Recruitment, which is an office that was set up to support the workforce in healthcare, and we established that office in 2021. And sometime along the way, I think it was in 2023, I became the minister responsible for healthcare infrastructure renewal. So I'm the minister responsible for the Halifax Infirmary Expansion Project and the redevelopment that's happening in healthcare in Cape Breton.
Oh, that's a lot. That makes sense, because looking at your track record, there are a few bills that you sponsored that seem to fall under those categories. So
Yes.
This has been priority for you.
Yes.
Oh, that's
And why are those different departments? Aren't they under health?
Well, the infrastructure renewal is such an incredibly big project.
True.
And so it actually does sit under Build Nova Scotia, which is an organization that is looking at a number of different things, including housing across the province, but really responsible for working with industry directly in order to get, appropriate tenders and making sure that all of the things are running the way they should. But what was really important for me is that the clinical aspect really informs the work that's happening around both of those buildings. So
Right.
it's not
Understood.
just a building, but the clinical information that needs to go into those buildings so that, number one, staff can work in it and so that patients can receive care in it is really essential. So that was where the fit comes. If there's any hospitals that are being renovated, it actually sits under Public Works, which is Minister Tilley.
okay. But your interest in the clinical side is logical, because for those who do not know, you worked as an RN for a long time.
Long time.
Yeah.
So
And
I'm a
we're-
graduate of St. Martha's.
Okay, and you were at
School of Nursing.
the RK.
I was.
Yeah.
That's where I started my career when I was 20, and I worked there for a period of time, and my career took me to other places and other jobs. And then prior to being elected, I was the CEO there for about 5 years.
Right. So becoming the Minister of Health seems an absolutely logical fit. Is that something?
Absolutely. It's a privilege, first of all, to be elected to represent Antigonish. You go on this journey as a politician. You don't really know if you're going to resonate with people, or if the party, or if the platform is going to resonate. So just to be elected was amazing. And then Premier Houston was elected and with a majority government, and appointed me as Minister of Health in September.
What got you into the politics?
Well, it's a good question. So I've always been interested kind of in what's happening. Health is a passion of mine. I had felt, without being too political, that, really healthcare was in a tough spot prior to the election. I felt that I had lots of experience in healthcare, and I deeply cared about my community and was involved in a number of different volunteer organizations, and I wanted to see if I would be successful. So I thought I'll try it. And I put my name forward, and I was so grateful and so fortunate to be elected.
So you won that election. I've got the data right here in front of me, with 49% of folks here voting for you. So you came out of the gate as a non-political person, just a nurse, a community person everybody knew, and you won your seat. And what do you attribute this to? Is it because people know and like you, or was there a platform issue you think that was resonating?
I think a couple of different things. I don't know. I always say nobody's on the fence about me. They either like me or they don't. So there might be some listeners who are like, oh, I don't like her. But anyway, I just love this community. I came here when I was 18 years old. I am originally from Cape Breton, and came up here to train at St. Martha's School of Nursing. I met my husband here, Darren, in my second year of nursing, and stayed. And so we've tried to be really involved in our community. I've had so much experience in my job. I've worked at the hospital. I've worked at St. Avex. I worked with the school board. I worked in Guysborough. I worked at RK McDonald. I worked in public health. I worked in Emerge. I just did a little bit of everything. And so, and then tried to give back to the community. We raised 3 great kids here who are adults now. And tried to be involved in the community, in their sports, and the things that mattered. So, again, I was so grateful for the community to put that faith in me.
Well, they put their faith in you, and then the next elections came up, and you had 65% of those. So you had done something that did not anger people in that time. So what?
They liked you.
They liked what? So you were somehow more popular. So what were you and or the government doing at the time that you think people were responding to, that you got?
So I think it was really important. Certainly, Premier Houston ran in the first election on healthcare, and that really resonated with people. Healthcare, I think we all can say, was really struggling for a lot of different reasons, and I think I really try to get back to people. I try to reach out to people. I try to be present in my community. Like I said, what you see is what you get. Usually with me, I have an incredible person that works with me, Wendy Chisholm. In the office, and again, someone with incredible work ethic, has worked in a physician's office for a long time, and so we really value getting back to people and telling people whether we can help or not. Sometimes we can't help, and then of course Vanjie Babin works in the office a couple of days with us as well, and so I just think we're responsive. We can't always give people the answer they want, but we do try really hard to meet with people, be present, and get back to them.
So you're an MLA from Antigonish, and so talk more about this, because you have an office here, and it must be the case that local people from this area are contacting you to help solve their individual problems. That's what you're talking about. So tell us, how many people are contacting the office, and what sort of things are they asking you?
And what have been some of the tricky examples of when you're trying to solve them problems? Give us a real scenario.
Yeah.
Okay, I'll try and think of something. So we see a number of people through the office on a regular basis. Sometimes people phone, sometimes people drop in. We're at 325 Main Street, so the old post office on the second floor. And so we help people navigate government departments. So sometimes I would say the biggest thing we hear about are the roads, and people wanting their roads to be in good repair. And we certainly have invested in roads over the course of our government. So potholes, grading, dust control are really big issues.
But only for the county, not for the town.
Right.
Right.
But so people are coming in to you to complain about potholes on Main Street?
100%.
And what do you say? Because you're like, well, I can't do anything about that.
Well, but we do try. So, Public Works is responsible for roads, and there's a different types of roads. There's J-class roads, K-class roads,
So you have learned
trunks
everything
and
about
routes,
roads.
yes, and ditching and all of these
Fascinating.
different things. Yeah, so I've learned a lot about roads, especially over the last 5 years, and so it is my job to advocate on behalf of residents about road repairs.
What does that look like in practice to advocate for residents?
Yeah, so we meet with Wendy and I meet with Public Works, so the local area manager and district manager. We meet with them probably every second month. We go over, areas where people are really frustrated with the roads, or we look at what's coming in the out years. So the 5-year road plan, what's happening. We talk about the priorities. It's my job, if there's a particular issue, sometimes I need to speak to the minister and say, this is an issue that's ongoing, and what are some of the barriers that maybe folks in Public Works are facing. And so, and the other thing we do is drive the roads. So if someone complains about their road or tells us it's in disrepair, I always try really hard to go and actually look at the roads to understand what is actually happening. It's one thing for someone to explain it to me, but I think it's important that I go. And so especially in the spring when it's thawing, or in November when, you don't get rain all summer, but it rains for about 20 days straight. And so, going and seeing the roads. So I've learned a lot. If the roads are too wet, they can't be graded. The equipment is really heavy, so the weight restrictions when frost is coming out of the roads, a rainy season, you can actually make the roads worse by putting this equipment on it. Just, a whole bunch of different things. Ditching, I can spot ditching now that needs to be done.
This is fascinating.
We never thought that you would be talking about roads.
No.
Right? Wow.
Like, it's crazy to imagine, like, if I came and complained about Pleasant Valley Road to you, you would then go, you and Wendy pop into the car, go out and drive it to see
Go look at it. Yep.
That's fascinating to me. I did not expect that level of commitment.
Or ditching or culverts or things like that. It's really important. And if you think, cars are expensive and they're a big investment for people and families. And so, driving over roads, and it's like if you have a big area or section that's full of potholes, it's the first thing you hit on your way to work in the morning,
I
and
know.
maybe the last thing that you hit on the way home after a hard day or a tough day. And so we can't fix every problem, but we do really look.
And you are Minister of Health for the province, but do you get requests like, I don't have a family doctor, or my mother is facing this challenge of, and how do I solve that? And do you get health related requests? Because
yes, so we do. The thing is, the constituency office in Antigonish is for the constituents of Antigonish. And so when I'm there on behalf of the MLA. And that's my primary job. Like, there's no votes for me in Halifax. Like, if you don't get to be the Minister of Health if you're not reelected. So I really do work really hard. And Wendy's a huge help to make sure that we address the needs. So within the constituency, that's where concerns go. Provincial concerns also come in to the constituency office, but we actually would forward those to the Department of Health and Wellness or Nova Scotia Health or IWK or whoever is responsible, because those individuals also have MLAs and it's a department issue. And so we don't deal with department issues within the constituency office unless it's a constituent.
wow.
Is what I would say. We have to be really careful about how we separate those two things, because my job really is to serve the individuals. And we, as ministers, serve at the pleasure of the Premier. So, my ministerial appointment could go away tomorrow. I don't expect that to happen, but, we do move around and people, have different portfolios. So
just to clarify this, you mentioned this very interesting thing that you are the minister, and so any departmental thing, you refer to the department. So if I'm correct, you are much more of a policy and lawmaker role as opposed to delivery role.
that's correct.
And is that kind of distinction accurate?
So we would say, as the Department of Health, as the minister, they would tell me, the folks that I work with in Halifax would say that I can have my nose in but my hands out. That's how they describe it. So
fascinating.
it's
Nose
really
in, hands
hands
out.
out. So oversight, we are the funder for health service delivery in a number of different departments, Nova Scotia Health, IWK, etc. Seniors and long-term care is a different department, and so they would be responsible for the care delivery that happens in long-term care facilities. And Brian Comer is addictions and mental health, and he and I share. So a lot of those services are delivered through Nova Scotia Health in those facilities, or staff that are employed by IWK or Nova Scotia Health. So he oversees some of the services and the delivery pieces, but I'm not the operator. So very often someone may contact me about an issue they're having, and we may actually refer them to Nova Scotia Health and or IWK, and just simply say, this individual has reached out, and it would be great if you would get back to them directly. So it doesn't always have to be me as minister. And because there are often so many concerns, I often will need to delegate some things, of course, to whether it's department staff or staff within Nova Scotia Health or IWK. But if it's a concern, I'm generally briefed on the outcome.
So you cannot tell a doctor to accept somebody as their patient, as a family doctor.
No.
Oh, okay. Just wanted to...
Yes.
That's
no.
the hands out part.
Yeah.
Yeah.
Yes.
But if you come to me as your MLA, as any MLA would, and you have an issue that you would like resolved, it's important that you come, or the person who needs the issue addressed, if they have capacity. So if they're of the right age, or that they are able to make their own decisions, and we get a consent signed, and we simply help navigate and say, I'm inquiring on this individual's behalf. This is what happened. Who can get back to them? Those types of things. And often in many departments, so there is generally, if there's an individual concern, a consent is required in order for us to look at a right-of-way, healthcare concern, something with the schools, anything that's under provincial jurisdiction, an environmental issue, those types of things.
So, did you have a question, Anish?
Yeah. So just a quick one. I think as somebody who understands health inside out now, hopefully, how has things changed in the last 2-3 years in Antigonish?
Mm-hmm.
What are some of the major shifts that you are leading or seeing in terms of clinics, in terms of mental health, whatever?
Sure.
What can you tell the Antigonish folks? Yeah.
Well, there's been a lot of investment in health across the province, but in Antigonish as well. We have a new EHS base. So you'll recall there was an EHS base over by Ron McGilvery's there. And
That's where the ambulances come out of, right?
That's where the ambulances come out of. And there was a small base, and I think there was 3 ambulances there. And now actually it's up over by Tim Hortons and Shell. There's a huge ambulance base there, and it's able to kind of house 9 ambulances. That is a big investment. We've put a lot of money into EHS, so the paramedic workforce has stabilized. We've introduced different types of classifications of helpers. There's a transport system now where non-urgent or just transfers between facilities is done by a different vehicle versus in an ambulance.
You were talking about that just 5 minutes back.
Yes.
Great. Wow.
Yeah. So that's been very helpful. Response times across the province are coming down. We've certainly seen an increase in the number of paramedics who are working in the field. We do also, just up by the old, I'm just trying to remember the name of the street off the top of my head. I know where it is, but it's hard sometimes. Over by Antigonish Wheel Alignment, if you go up, it's up by Access Nova Scotia.
Oh, yeah.
There's a new great big collaborative care clinic. And so
Lots of people are asking about that.
I know. So we expect that to be open very late winter or early spring.
Okay. Great.
And we expect roughly 25 to 30 healthcare professionals will work in that facility, not only physicians, but you can expect nurse practitioners, family practice nurses, potentially dietitians. And there's 2 incredible clinicians leading that work. And that's Dr. Brittany Bear and Dr. Jane Ann Howard. And so those 2 physicians are working to build that team and to support physicians moving. So some physicians will move that currently exist in other offices. They'll move to that space. And whether or not there's new recruitment, I can't really say yet. But we believe, or the expectation is, roughly 10,000 people will be attached to that clinic. And you can expect evening and weekend hours. Those physicians will also come.
There's good news
Is that
coming.
a potential walk-in clinic?
I would have to check with the folks just to be kind of sure what the services are that they're going to offer. But it will have same-day, next-day access as an example. Some of those physicians will also work in the hospital to cover the hospitalists. Some of them work in Emerge.
What's same-day, next-day access mean?
So often we talk a lot about attachment, which means that I have a primary care provider that I go to on a regular basis, and we talk about access, and they're not always the same thing. So you may have a clinician, but it might take you 4 weeks or 5 weeks to be able to make an appointment.
100%,
right?
Yeah, that's so common.
And so one of the things we're looking at across the province is how can folks leave same day. So today, I call in the morning and I have appointments available today, or next day for more urgent things to prevent people from maybe not coming to the doctor at all or showing up in the emergency department.
Okay, so that's sort of a walk-in almost.
Kind of, yeah.
And it's because we don't have anything like that at the moment.
No.
And that's definitely happening at this new clinic or on the table?
It's definitely on the table. And it's part of the work that's happening. And I think, as the team is being built and as we get closer to kind of launching and opening the doors of that clinic, there'll be more information.
Who owns that space?
So it was tendered. So somebody built that. A company named Parsons built that building, and so Nova Scotia Health has a long-term lease, and so it will be a Nova Scotia Health clinic. So there will be, folks from Nova Scotia Health working there. Perhaps the admins, physicians will go into that space. The majority of people will be employed by Nova Scotia Health, and will also kind of fall under the policies and procedures of Nova Scotia Health.
And is that an experimental idea, or is it happened before somewhere?
It's happening across the province. It's kind of a turnkey model, and what we're looking at is a model of care called health homes. And so in the old days, I think about my time and growing up in Cape Breton, we went to the doctor for everything in rural Cape Breton. So you came through one door, there were 3 physicians. It didn't actually matter who you saw. They would all see you, they knew you, but you went for everything. Now we see, people are more complex, our treatments are a bit more mature, those types of things. So in fact, you may go and actually need to see a dietitian, or you may go and need to see a social worker. Or for an example, if you have a well baby checkup, and actually a family practice nurse can give the care to you and your baby and then flag if there was anything out of the usual to either the nurse practitioner or the physician who was ever appropriate. And so what we want is people attached to the clinic. And that's where your health home is. That's where the team is. And it immunizes us against physicians or nurse practitioners or whoever who may have to leave unexpectedly or retire. And so we recruit to the clinic. And arguably newer physicians and nurse practitioners and clinicians coming into the system, they want to work in that team-based environment. Whereas in, former practices or more mature practices, physicians generally worked alone. And they worked in a different model of care. They didn't often have nurses. If they did have nurses in their offices, they paid for them themselves. And so the government is supporting these health homes. And what happens in those primary care health homes or collaborative care centers is really important. So once we build the teams, then we'll build the standards. But what happens there? When do we refer to other people? What are the core competencies of each of the people that work there? Just to kind of make the system a little bit more standardized across the province. And then we'll look at health neighborhoods, which may include your pharmacy, your long-term care facility, your local hospital, all of those types of things.
So this sort of replaces the family doctor system. In an ideal system, it's health homes that you're registered with, not an individual physician.
That's the ideal.
Okay.
And not all physicians have to sign up to that. One of the things that has happened in the province is we've changed or provided a different option for the way physicians get paid. And so it was called fee-for-service in the old days, so you get paid for who you see. And then we had an alternative payment plan, APP. But now we have something called longitudinal family medicine. Just rolls right off the tongue, and it's called LFM. But we actually we support physicians. So you're a new physician and we say, okay, this is going to be the number of people who are attached to you. And we, through data at the Department of Health, we say, this is a complex group of folks. There's a high amount of chronic disease, as an example. So you're going to see 1,000 patients, whereas someone else might have 1,400 patients. And so we help identify a group of individuals that we attach to you based on their complexity, because it isn't always, not all patients are the same.
Yeah, geriatric patients are fundamentally different from pediatric.
Exactly, from a 21-year-old with no health care issues. So we want to have a good balance. And then for every, other things are incentivized. So if you attach more patients, you feel you have the capacity, then there would be additional payment for that. If you have evenings and weekend coverage, and patients are able to see you at those times, then there's, remuneration for that. If you cover your local nursing home, there's...
I see. So there's a base salary based on those parameters, as opposed to billing per visit or a phone call.
That's right.
So that is a very different system to what we currently have,
yes.
I have to say. And is that a thing that is definitely happening, or is that just a discussion?
No, it's definitely happening. It's definitely, I think it was 2022, possibly 2023, when we negotiated that contract with Doctors Nova Scotia. And so we have an expectation how many patients would be seen in a day, those types of things. And physicians in the LFM model actually get a report card on a quarterly basis. If they've seen more patients, then they get additional funds. And if they haven't seen enough patients, we need to understand why. And if it's consistent, then they may have some of the funding that they're allocated clawed back.
Yeah. So, people for me, I am with Dr. Cudmore. So what is the implication on, for doctors like Dr. Cudmore, who will continue to, I'm sorry, I'm just taking his name because that's who my doctor is. What are the implications for them in this new system? Is it running parallel? Is it collaborative? How does that work?
Yeah, so all the physicians get to choose with physician services at Department of Health the way in which they want to practice. And so they can practice in team-based, they can do longitudinal family medicine, they can still remain to do fee-for-service. So, we want to give physicians flexibility. It's been very successful. We've been very pleased. The majority of physicians in Nova Scotia, I can't speak to any physician in particular.
I agree. Sorry.
But many of the physicians in Nova Scotia have come on to this model. And what's important is not only, are the expectations there, but we monitor the expectations and we gather data, because it helps us manage the healthcare system. And, we didn't always have access to a lot of data, but we've worked really hard as a government to build data systems to understand how many people are moving through the system, what are people going for? We also are trying to understand how communities move. So if you're attached to a physician in a certain area, how far away, and is that how communities traditionally move? So, where is your preferred location to be attached to a clinic? As an example, folks in Sherbrooke sometimes come to Antigonish for a number of different things. We move amongst communities in a different way.
So as a minister, you have access to that analytics to be able to make some...
Yes, we have a lot of data analytics. It's all scrubbed, so I can't say, Anuj, I know exactly where you're going, and I don't have access to those things, right? Any personal, individual health data,
right.
It needs. If I were to ever have access to it, it would be based on consent and all those things, because I know people worry about that. But we look at aggregate data, so it's anonymous data, but it could be by community. And so I don't know the names, but I can, with data analysts, that's for sure. I don't know this work. We look at, how many people are accessing emergency rooms based on their triage score. And so, does this community need a rapid assessment zone, as an example? Would they benefit from a physician assistant? So we're constantly trying to adapt and understand the health of populations and communities and how we best serve them. And so we're getting better at that all the time. We're still maturing in that space, but we're also working across jurisdictions. So we've been to Denmark to see how they manage their system. We've been to London to see how they manage their system. And rather than trying to figure it all out on our own, we take the best ideas and we bring them home, and it allows us to implement things more quickly.
That's the single smartest thing I've ever heard, because there are medical systems in Europe that function far better, and so you are learning from them as opposed to reinventing the wheel. Love it. Big fan.
Beautiful.
But my question, the LFMs here in Antigonish, when can people start seeing, I'm now part of an LFM?
It's a collaborative care. So the LFM is just the payment model.
Oh, sorry. So collaborative care. So because at the moment I have a family doctor, like am I expecting her to switch over to this collaborative care system in the next 6 months?
Well, if she wants to, I guess that's what I would say. So there are clinics. So you can expect the collaborative care clinic would be, our primary collaborative care clinic will be at that Beach Hill clinic. That's where you'll see it first.
Okay.
There are other folks who have come forward and have talked to physician services in Nova Scotia Health about the ability to kind of move to that model. We would build that clinic first, and then we would understand what are the other needs, and are there other clinicians who would like to join together in that collaborative model.
And how does this work in terms of physician recruitment? Is this a model that is more appealing to a young physician, for example?
It is. It's appealing to new physicians who are coming into the workforce, and all healthcare professionals, actually. But it also is very supportive for internationally educated graduates. So you're coming into a practice that has have a number of different clinicians. So possibly new clinicians who have been in the system for a long time. For a short period of time, I worked overseas. And so I was over there. I would have been an internationally educated nurse. And so many things are the same, but there are lots of things that aren't the same. And so to have colleagues that help you understand the system, move you through little things like, where do I get groceries? Where do I get a babysitter? Where do I do all of these different things? What are the fun things to do in a community? Those things are all important when you situate somebody new to the community into a practice.
In many ways, the way you are explaining it, you are creating, incentives and options for people and inviting them into different systems, as opposed to forcing that on the whole health system. Is that accurate?
It's accurate. And one of the things we did, so we were elected, and then I was appointed as minister, and one of the first things we did was travel the province. We did a Speak Up for Health Care tour. So for 3.5-4 days, we traveled around the whole province, and we spoke in small groups and bigger forums with healthcare workers to understand what were the things that were barriers to a world-class healthcare system. What were the barriers they faced as clinicians? What were their frustrations? Those types of things. And from those voices of healthcare workers, we built Action for Health, which was a 4-year plan. We're just coming up to kind of the end of that initial planning period. And we had 6 solutions, which I will try and remember off the top of my head if asked. But, what are the things that we could do? How would we build the workforce? Where would the investments be most helpful for patients and clinicians? How do we look at the population of Nova Scotia? We have an older population. We have a lot of chronic disease, those types of things. So what would help us improve the overall health of Nova Scotians? And so Action for Health is available. You can, Google that. And we also have regular updates about how we're doing, where we've done well, and maybe where things were more complicated than we expected.
So I have a lot of questions from listeners because we asked listeners for questions, and a lot of them are based on are focused on health, which makes sense. Some that are not. But before we get into those, I want to just circle back to you as a human being, friend, and neighbor, because people are still interested in you. And so there's a couple questions that we got specifically about that. One of them being. When you started this job, you might have had expectations, and now you've been at it for a long time. Can you tell us what is different from what you expected, either in a positive or negative light?
So I've learned a lot. I've learned a lot about my community, and in some ways, it's made me like I know more about my community. But in some ways, also anywhere I go now, I am representing government, and so in some ways, it's kind of pulled me away from some of the things that I used to really love to do. But for the most part, people are amazing, right? Like but I also know that I represent government any table I sit at. So it's a little bit different. It's mostly what I thought it would be. I don't cry as much as I thought I would. I thought I would cry more. But I have so many, because, it's hard when you're a helper. It's hard when you're a helper. And sometimes people have really difficult things happen in their lives or you can't help. And so, I have so many people around that really do help me navigate. I have good relationships with the municipalities and with my federal counterparts. We work really hard locally to maintain those relationships because we're all serving the same people. And I know not everyone across the province has those same relationships, and I'm grateful for that. Doesn't mean we agree on everything, but we carry our roles with respect and collaboration.
So you would interact with the mayor and the ward and the councils and
yes,
our member of parliament on a regular basis. As a group, as an individual, how does that
both
function?
Both. So I have pretty regular communication with both the town and the county, and with MP Batiste as well. So I'm getting to know Jaime. Prior to this election, our MP was Sean Fraser. So Sean was really helpful. He gave me a lot of good advice when I first started out about what it was like to be a politician and, things that he'd learned as well. And
so that doesn't go against your party divides, and that's fascinating, right?
Yeah. And I have a question about being the face, because there's been a few times when something has gone very wrong with the system, the medical system, and the government has had to essentially apologize or explain what has gone wrong. And then you become the person on television apologizing. As a human being, like, that must feel very strange because you aren't personally responsible. You're part of a bigger system. Like, that must be a bummer. Is that hard? Did you have to train to do that, or?
It's been hard across my career. So, we are all human, and sometimes individuals make mistakes. Sometimes the system doesn't catch people in the way that it should in terms of healthcare. And so I've experienced that over the course of my career.
That makes sense. Like, as a nurse or a physician, of course, you have to do that all the time, I imagine.
Yeah, and to talk to people about really hard things. And so you have to show up humbly, and the hard part is you can't often change what's happened, but your commitment always has to be to make things better and to be sorry that people have experienced something really difficult. And so, and we do want to do better. When we hear something's gone wrong, someone hasn't gotten the care they required, it is really difficult, and we need to be present for people. And I think, now more than ever, citizens expect people in leadership roles to walk towards hard things and do it with integrity. And, it is hard sometimes, but I have lots of people to help me. And I get a lot of media prep before I go into the media.
Sure.
And to date, the media has been very respectful. They have a job to do, and I appreciate that job. And I have a job to do, and I try to give them as much information as I can when I'm able to do it. I think it's just better for everybody.
Yeah. So before I get into other people's questions, I just have one politics question that has fascinated me. When we were talking with Senator Mary Coyle, she was talking about how the Senate works these days because of the recent change, where whipping is not a thing anymore. That is, you can be an independent person and you don't have to worry about...
In the Senate.
In the Senate, where you're not meant to be towing a party line as much. I mean, they do have I think the PCs have some Senate. Small, she was saying, but it's not that big a deal. Whereas in the Canadian system, across the board, in parliamentary systems, I think more so than in the U.S., whipping is an important part of it. And so that means that as a member of the party, or you're currently a member, PC member, they are the government, you are expected to vote a certain way. And if you do not vote a certain way, this is true of everybody. If you don't vote a certain way, you could be thrown out of caucus or lose a ministerial position. But as a human being, there's no way that everybody in that group all agrees that what the government is doing is exactly what they believe. So not just you personally, but the other MLAs, like, how do you guys deal with this problem of like, I really don't necessarily agree with this, but I have to vote this way? Is that something that is bothersome?
Or has that, do you have an example that, where you had to make that hard choice?
You don't have to give specifics.
No.
Because I don't want to get thrown out of caucus.
No, what I would say, so caucus, of course, is all of the people in the same party who are elected, right? And then cabinet are the people who are the ministers. And so they kind of sit and make different decisions. But, in caucus, we can have some pretty heated debates without saying too much. So that's kind of where we work the details out. And, we have quite candid discussions there. We're a big caucus now. So there's about 42 of us, I believe. And we're very fortunate. So we have caucus roughly every second week. And the Premier sits with us for at least 3 hours every second week, which is very admirable considering all of the things that he has to do. But we spend that time with him and we talk about different policies, we talk about different things, and we hear from him directly. We're able to, ask questions, argue a little bit, those types of things. So we kind of work through that. And, so far, it's worked well, is what I would say.
But so you are debating, because not everyone is on the same page. You're debating, and then you have some sort of consensus, and then you all agree, okay, we're just going to do this.
Yep.
So it's like a compromise, of course. Yes. Government is compromise, right?
That's right.
So that is part and parcel of what you do.
Yeah. And sometimes there may be a portion that you don't agree with. And so you just, we have those kind of it's like, you air those concerns and sometimes things change a little bit as a result of those conversations. And so to your point, there is compromise, or we say, okay, this is the first step. And then thank you for that feedback. And, I do it myself, right? In terms of my colleagues with my own ministerially, this is what we want. And so I kind of say, well, that's not really an option, and this is why, or this is an option. And so it's more of a process other than a hard stop.
And the calculation must simply be, as a member of the party, you have access to more resources. You can be in the government in a cabinet position, which gives you more power to help and do the things you want to do. So if the option is like, I'm going to be an independent because I don't agree with this, then you essentially lose a lot of power. That must be a calculation that most people are making?
It could be. I think for the most, often when you belong to a party, you're often not completely like-minded. Like, we have certainly diversity of thought, but for the most part, we are like-minded. And the other thing I would say as a sitting minister and as a government, regardless of party lines, it doesn't matter to me what we would say your stripe, what your politics are. Like, I am the Minister of Health, or I'm the MLA for here. And once I'm elected, my responsibility is to everybody. And so regardless of that stripe, I have a duty to help where I can, regardless. So in some ways, once elected, you're nonpartisan in many ways. As a governing party, or government, you have things you want to see happen. And often, if I were to be honest, almost all the parties want the same thing. It's how we get there is different. Yeah. It's really, if I were to say, what are the top 3 things, I suspect each of the parties, and probably the independent members as well, would say, with little variation, it's how we get there, or what people's perception is of what we're able to do.
Yeah.
Just on that, if very quickly, I think if my information is correct, over 30% of our provincial budget is health. Health sector is the largest employer in our province. So it's not just health; it's economy, it's labor. So it's a very large, complex portfolio file that you manage. and we also classically the left and the right and the center, often the right or the center would say we need to create more private sector approach to public service, and the left of the center would say no, we need to run this from the government, and that's a classical debate. Where does PC sit on that? Do you face that ideological debate, or where is health sector in our province from that perspective?
So Nova Scotians don't ever have to worry about paying for insured services. So we actually have a whole number of services that are publicly funded that we pay for. We do actually have some private healthcare in our province already, so that we use our private insurance for in order to access, or we pay out of pocket. And so, you can look at things like private physio clinics or massage or dentistry, those types of things. So there already exists kind of a private system that we coexist with. And we cover where we can for certain populations of people in some instances. So what I've learned in this role is about public-private partnerships. So there's no movement at all to privatize healthcare. We believe that it's an important right for people to access healthcare. But we have to also look at the way other people are doing things. And so public-private partnership really came into the forefront for me when I visited Denmark and really started to understand, ways in which private sector is able to support research and innovation, those types of things, still publicly funded. And I'll give you a great example of how we can leverage those partnerships. When we, prior to me being elected, but in government, we had to, and we're happy to, have pharmacists give us our COVID vaccinations. So they were available across all corners of the province. We could have gone out with mass immunization clinics as a system, which we did. But the efficiency in our ability to get to small communities all over this province and our vaccination rates were high because we depended on those private sector individuals. So you could get your COVID vaccine anywhere in the province. There was no fee associated with that. So that would be a good example of a public-private partnership. So it's an insured service. There's a tariff associated with it. We pay for that, and people are still able to access the care.
There you go. It's a good example. So I've got a bunch of questions now. I'm going to stick to the health ones first because we got a bunch. There are some other areas I'd love to know more about, but we can't probably get to all those. Mm-hmm. But let's start with this one we got about addiction treatment access. So this is someone saying, and maybe this information is incorrect. So there are no publicly funded residential addiction treatment centers in Nova Scotia, and inpatient detox is frequently unavailable. So the question is, how do people with addictions get services and help without those kinds of clinics available?
So there are day programs. That's accurate. There is no publicly funded inpatient detox center. We used to have a number across the province, and we've moved away from that model of care. And so now there are day programs, walk-in clinics, those types of things around addiction services. And there's a very fulsome website that kind of helps you navigate to the care that you require. I would, without speaking fully on Minister Comer's behalf, it is something that we are thinking about. Our ability to be able to deliver that, depending on budgets, etc. But that is accurate, and so currently there are only day programs for people that are kind of detoxifying from whatever substance use, and lots of support. And there's also, in addition to those day programs and mental health services, through the day. I just would like to say that 211 also has support lines available, the men's helpline, and then a general helpline as well for individuals outside of regular hours. If they are feeling that they need some support, you can call 211, and there is an immediate help on the line to help you through that moment, which can be very difficult. So that point's well taken. Minister Comer and I talk about that. There is more work to do on addictions and mental health in our province.
So there's discussions to build these sorts of facilities.
I can't make any promises, but certainly something that we do have our eye on. It's on our radar.
Okay. And then, of course, the perennial question of where are we at with new physicians? I mean, we talked a little bit about this with these the new system, the community centers. But how does that do? That's sort of in the works. But at the exact moment now, how are things looking with recruiting new physicians? Where are we at with family doctors?
And also just the whole idea of having a family doctor. What is the kind of overall situation in our province?
Sure. So, we have done well in Nova Scotia recruiting primary care providers. So the family physicians, nurse practitioners would be predominant deliverers of primary care in our province, and also pharmacists. So pharmacists also can fall under that primary care provider as well. So overall, we're doing well with physician recruitment. We have a number of so we've increased the number of seats that are available to train physicians in the province, and we have a new medical school in Cape Breton, at Cape Breton University, with a focus on family medicine, predominantly in rural communities, because practice sometimes in an urban setting is different than practice in a rural setting. So we're looking at that. Internationally educated graduates, particularly mid-career graduates. We have a new program called PACE, which is the Physician Assessment Center of Excellence, and that's based predominantly out of Halifax. But if you are a mid-career physician, you can come into that PACE clinic, start to see patients be observed and assessed by physicians who are fully credentialed in Nova Scotia. And if you're suitable, if you're ready, within 12 weeks, you can actually have a conditional license and go and start to practice yourself, which is really important. We passed the Patient Access to Care Act. So if I were to go to Alberta and get sick, I wouldn't say, I only want a Nova Scotian nurse practitioner, or I only want a Nova Scotian physician. I appreciate and recognize that our counterparts in Alberta or any other province in this country have rigorous licensing procedures. So if you have a license anywhere in Canada, you are able to practice here and in good standing, meaning that there's no complaints and that you don't have any decisions against your practice in the past. You actually can come and move here and start to practice. So we've looked at ways that, number one, we have in-migration, so from other parts of the province, people wanting to return home. We also have an Atlantic licensure, so between Nova Scotia, PEI, Newfoundland, and New Brunswick, if you're licensed in those spots, you can also license in Nova Scotia. So sometimes, you have a cottage somewhere PEI, or someone from PEI has a cottage here, or you're in Yarmouth and you have family in Judic, you can work in some of these hospitals and we can allow you to have some economic mobility. So that's really where we are. Our recruitment numbers are very good. I don't have them in front of me across the province, but certainly family medicine has been positive. We have some spots for sure, like a good portion, almost half of our population, or about half of our population, is in Central Zone. And so, we see that there's people there that need, because there's such a concentration of folks. And the other thing we did is a transition into practice and a transition out of practice. So if we know that a physician is retiring, or a nurse practitioner, if we have some lead time, we can actually recruit to that practice. So that's what recently happened in my practice.
I have a question now, because I'm pulling this news story out of the recesses. What is the word? Out of the dark corners of my mind. Yeah. So tell me if I'm wrong about this. Yeah. But wasn't there a thing that happened where you had a list of the number of people waiting for a family doctor, but then that data was sort of unreliable, and you're like, it's really difficult data to work with. We're not sure of it, so we're no longer publishing it anymore. And so you don't currently have numbers on the waiting list. Does this sound familiar?
Yeah, we do have numbers on the waiting list.
Okay.
But so the what we used to call it was the doctor list, or the list. You'll hear people say, I'm on the list. I'm on the list.
Yeah.
And so it really was a list of individuals, and it was not functional in that we maybe didn't have some information. So now we call it a registry.
Okay. So it's a registry.
It's a registry. And so if you don't have a primary care provider, you would call 811 or go to the website. You would identify that you need a primary care provider. You would put your name, your address, your information in there so that we can understand, what your clinical needs are. And so what's important about that is there are people who are actively managing, really urgent treatment or urgent health issues or chronic disease issues, and we try and get you attached to the appropriate provider. Anybody on that registry, regardless, has unlimited access to virtual care. So you
say a little bit more about virtual care.
Yeah, so virtual care, you get to see a practitioner. You would go on, you build an account. You can actually do it through your app, which is a really important tool I think that Nova Scotians could use. You go to virtual care. So if I'm on virtual care and one of you is the clinician, you may say, you know what, I think you need to see someone in person. This is something that needs to be seen in person. And so we have primary care clinics across the province where they say, okay, where are you located? And we're going to get you an appointment in the next 48 hours to be seen in person for this concern, or potentially this isn't something that can wait and we actually think you should present to the emergency room as a result.
Would you know how many people have started using this? Because this is fairly new.
Yeah, I don't have the stats in front of me, but I could certainly get them. It's well used. And through the app, if you do have a primary care provider, you actually can get a couple of virtual care appointments free of charge, for whatever. So, if you have a very simple health complaint, what we would call episodic care, you can actually be seen in virtual care. Say you're prone to urinary tract infections and they're fairly, straightforward, or you're prone to certain conditions. You could actually go on there and say, I've had this in the past and this is how it shows up. And maybe you could have antibiotics, or if you had a rash, they could prescribe a cream. And so there's just different ways that you can access care. Also, the primary care clinics in pharmacies. So you can go on to the Pharmacy Association of Nova Scotia. You can type in your concern and they will give you an appointment locally and tell you where some appointments are. But if you go into the Your Health NS app and there's a little button that says Get Care, that allows you to navigate, and that app will help you navigate where you are. Or if you're traveling, say you're in Bridgewater for a meeting or a hockey tournament or a band, competition, you can go onto that app and say, okay, this is where I am. This is the community I'm in. These are the symptoms I'm having, and they can tell you what the resources are locally.
All right. So, just to clarify that, the list, there's not the thing. Now you have the registry. And it is the case that the government doesn't have very reliable numbers that you can talk about now in terms of how things have been progressing? Or?
We know the numbers. Yeah, I think there's around 66,000 people. So we know that about 94% of Nova Scotians are attached to a primary care provider.
Okay. 94%.
94%. So
you're comparing that to the old list, but that's not really reliable comparison.
Well, it's our population. So we know based on who has registered for that list. So I think it's...
Oh, I see.
So our goal was to get to 5%. So we wanted to have a static number of 5%. And so I think we're at about 6.4% now in terms of people who are deemed unattached and are on the registry.
So the 66,000 includes family members?
Yes.
Or are they just... okay.
Yes.
Yeah. Like a family of 10.
Yeah.
Got it.
So
10.
we continue to look at that registry and say where folks are, and then also kind of help people understand how to navigate the system in the absence of a regular primary care provider. But in these primary care clinics, I think there's 19 across the province. Sometimes patients can go there and be seen on a regular basis until a permanent provider is found for them. So sometimes you can go for one thing, but other times you may have something that really requires you to go back 2 or 3 times.
So we've been chatting for a while, and there's a lot of questions. So we're going to have to wrap this up. So I'm going to ask one more health question, and then I'm going to sneak in one non-health question that I think you'll enjoy potentially answering. And then we'll give you the final, talk about whatever you want sort of thing. But here to go. Your last health question, and this is the one I think that crops up the most, which is where are we at with emergency room waiting times? Because if you look on Ask Antigonish, I feel like every fourth question is what do the waiting times look like at the hospital? That is a big question on everyone's mind all the time. So have things been improving, and what is planning to be done to make things better?
Yeah, so across the province, wait times are improving in the emergency department. And so, on any given day, of course, it could be a difficult day, but the first thing folks should know is people are seen based on their triage score, and that's existed over a long period of time. So number 1 is, the most critically unwell, most urgent, and number 5 would be something that, potentially you could be seen in an office for, or in a pharmacy for, or what have you. It could be a prescription refill as an example, providing it's not, an urgent prescription refill. Just to give you an example. And so you have the triage score, and obviously the sickest people are seen first. So there's a number of things that are happening in emergency rooms across the province. So some have virtual urgent care. So we may say, based on your triage score, you know what, it's going to be a fairly long wait, but there's another stream that you can go through. So virtual urgent care, you can actually be seen virtual with the assistance of someone to actually have that.
right there at the hospital,
there.
like you're on a terminal.
That's right.
Okay.
And so you can be seen there. There's a virtual emergency support as well.
And that's happening at Sister of St.
Martha's,
as
yeah.
well?
There is some virtual care, and also we have rapid assessment zones in a couple of different places
What's
too.
that mean?
So rapid assessment zone would simply be that. So if you come, look, we would often see that maybe in a respiratory season. So we see people with respiratory systems, and we may have a separate line just to help people get through. Is it viral? Is it bacterial? Do you need antibiotics? Do you need? So we can kind of move people through the system. But actually, some of the work that's been most important is happening in communities. So long-term care. So the emergency room is really a symptom of what's happening.
True.
Across the system. So if we have 100 beds in a hospital and 30 of those beds are individuals from our community who are waiting for long-term care or home care services or what have you, seniors who are, frail and not able to return home without some assistance or perhaps go to long-term care, we now really have a 70-bed hospital where surgeries can be done, where people can be admitted to, all those types of things. So Nova Scotia Health has worked really hard on a few things. So looking at, we're the only province that has this, it's called the Care Coordination Center. It's called C3. It's a big, almost like a call center if you were to walk in, and every bed is visible on the board, and people are helping move people through
Is this
the
province-wide,
system.
or?
It is province-wide.
Okay.
And so really helping, making sure that folks are discharged on time, looking at just different ways to support people, building a number of long-term care beds. We have early mobility and frailty reduction teams in hospital that get some seniors up and going really early in their hospital stay, because you know yourself, after a couple of days of laying around, you can often feel weak and a bit unsteady. And so if you have, if you're advanced age or you have other healthcare conditions, you can kind of lose function really quickly. So they want to get you up and moving and really help you maintain your strength, so that isn't the thing that prevents you from going home as you recover from your illness.
And the data saying that we are reducing, would you have like an average number?
Yeah, they actually, there was a number given today, but we've seen overall reduction in the average wait time by about 6 hours overall in the departments.
By 6 hours. That's great.
Yeah, but any given day,
Yeah.
we can't always
You can't
say.
predict, yeah,
we
but on
can't
average,
predict
okay.
on average. And we're trying to give folks, sometimes you wait to get into, the kind of, you sit in the waiting room, but we want to initiate treatment. So we actually have emergency room care providers who may start your blood work in the emergency, so that when you actually get into those little rooms behind those doors, your care has already begun. And so just looking at a variety of different options, and we're constantly looking at how we can support people in navigating them through the healthcare system, because it's frustrating when you're sitting there and people aren't there if they don't want to be. And so really helping people to say, can you would this be suitable for a pharmacist? Would this be suitable for, virtual care? Are there other ways we can get you the care that you need if it's not an emergency situation? So always trying to refine that process.
So things are improving and looking up. There's a lot being done.
And as somebody who has come recently to Antigonish and waiting for a family doctor, what realistically we can see, who just came yesterday, for example, maybe from Alberta, maybe from Toronto, what can we expect? What's the waiting time for that? Would you know?
No, I can't really tell you because it's based on recruitment. But what I would say to anybody, number one, apply. If you're just very new to the province, make sure that you apply to get your Nova Scotia health card right off the bat.
Right.
And then once that you have that health card, you can apply for, you can go on the registry. And that registry kind of understands where you're at. If you come and you live with diabetes, as an example, even though you may not have a family care provider, we can attach you possibly to the diabetic education
it's
center.
A very different way to approach it.
Yeah. If you are pregnant when you come, well, we want to attach you to prenatal care to make sure that you are, getting the care that you require. You have virtual care. We have the primary care clinic. And so we just, there's
so
options
the family
available.
doctor doesn't become your funnel. you can actually go into different streams depending on
That's
what
right.
the urgency of the need is.
That's right.
Fascinating. I didn't understand that before. Wow.
Yeah. So I'll pivot to my non-health related question, but I'll just list all the things that I want to talk to you about that I'm not going to, but because you are a spokesperson, of course, for the government, and these are all government issues. I'm just going to quickly name them. Housing, everyone always wants to know about housing. Universal basic income, that's something that has cropped up. Love for you. Maybe we're going to have you back as the spokesperson for all of the government. And fracking, currently in the news. There's just someone is petitioning the Dalhousie professor who's part of the government's $30 million
and he actually teaches here.
Yep, John Langdon. So listen for John Langdon in the news talking about the fracking issue, kind of a big deal at the moment. But I'm not going to pin you on fracking. Instead,
not this time.
Yeah. So, but yeah, not this time. I'd love to have you back. I'd love to have you back and talk about fracking.
I'm glad that you are still thinking of coming back. Thank you.
Yeah, exactly. That's why I don't want to get too deep into it. I want you to come back. But we are in the library, and a lot of people on the list have said, and we did an episode on this, and then there's a whole campaign here about library funding. So what are your thoughts on the fact that the library needs more funding, and that has been a loud and clear a statement based on how important this library is? I'm talking about the People's Place specifically to this community, as if we all accept that.
Yeah, and not to just put you on spot on that, but I think, what we have hearing just on the podcast is how everyone, without exception, sees this space as their space. It's beyond library.
Yeah, we are currently
and
podcasting.
you know this. I'm not.
We're currently podcasting in the library.
Right.
This is why I'm asking it, just because we happen to be here.
And not just as a minister, as an Antigonish. How do you respond to that?
So there's no argument about the importance of this library in particular, and certainly, there's a number of services beyond books that are offered here.
Right,
there's a CAP site here. There's also people who access virtual care here.
What
for
doesn't
health.
get offered here? Really?
Right.
Massages. That's the only thing I think of.
Well, could happen.
Orthopedics.
So, I know. So it's and there has been funding. So there's base funding, and then over the last number of years, the government's invested in libraries across the province around $800,000 annually to kind of top their funding up. And I think this library in particular gets around $65,000 or $67,000 annually over the last 3 years to top up. So what I would say is we're coming into a time of budget. We've heard loud and clear from the Pictou Antigonish Regional Library Association about how important it is and the need for funding. I would say that right now, the budget, I think this will be our toughest budget that we're about to deliver as government. Things have changed, and I can't forecast. It's not my department. I can't forecast. And certainly the letters that have come in, all of those have been sent to Community Culture, Tourism and Heritage through my office. And so we do what we can. What I have learned is that there really is no shortage of requests, not just from the library, but just across government. And, it's hard because we wish we could do more all the time. So I can't really forecast what's going to happen. I haven't heard, we haven't really finalized the budget yet. And we'll have to go into the legislature and debate it and all of those things. So what I can say is I've heard loud and clear. I've certainly advocated with my colleagues. And so, the Treasury and Policy Board and the folks that kind of look at the budget and finance are seeing all of the different requests and trying to use the resources we have to the best and highest use. But it is going to be a different budget than we've seen. We've had tons of investment in a variety of different things. And so whether we're able to sustain that remains to be seen, because we really have three levers as government. We can increase taxes, we can reduce services, or we can build the economy. And, to some of your point around our natural resources and renewable energy and those types of things, we really are focused on the economy in order to create more economic revenue in the province, in order to continue to deliver and expand programs that people want.
That's logical. We'll see if that's a good tact or not based on our upcoming conversation. But I will say this, what's nice about a representational democracy that we currently live in is that if you are a citizen who has an issue, like you have, you want library funding, or there's potholes on the road, you can literally go up to Michelle, our friend and neighbor at the office, and say, this is what's on my mind. This is what I want help from you personally or from the government. And in this kind of democracy, the squeaky wheel is the one that gets the grease, right? And so the more people are complaining about library funding or fracking or potholes, whatever it is, to the more representatives, all the representatives, the more likely you are going to want to bring this up in caucus and talk to people about it, because that's the reality of human nature. So in that sense, your role and you as a human being are very important to democracy in this town. The fact that you are out driving roads with potholes to interface with your constituents' issues directly warms the cockles of my heart, Anuj.
Yeah, I know you said that you would like to kind of conclude, but I am just kind of wondering if I can just pose this as a conversation more than a question. In the last, especially a year, if not 18 months, conversation across Canada is shifting a little bit. And we are seeing Antigonish as well becoming more diverse. And often by misinformation or by people who actually believe are connecting health crisis and housing crisis to immigration. And this is a national conversation, not just Antigonish conversation. And within health, we are trying to attract health professionals from outside, not just from outside Canada, but also from other provinces. And so, how do you see this playing? Is immigration a problem in health system, or is it because of immigration? Give us a sense of how do we navigate this, because everyone in the community in Antigonish, especially the newcomers, have this question on their mind. And both Justin and me are relatively newcomers to this town. And actually, you came after.
I'm newer. I'm much newer.
Exactly. And so, so just share with us your thoughts on that.
Yeah. So as a province, Nova Scotia really only has oversight of kind of the economic stream of folks who are coming from outside of Canada. But we see in-migration from other provinces too. And so
almost 33% of newcomers to Nova Scotia are from other provinces.
Yes. So, we want people to come and live and work here. The diversity is really an important part of, who we are as a country. I think it's important that people come here. We feel safe. We welcome folks. So part of our recruitment strategy is internationally educated clinicians. So the College of Registered Nurses recognizes credentials from a number of different places throughout the world because it's so similar to our training. And so we recognize those credentials. Internationally educated physicians, as an example, are an important part of our strategy in order to attach people and make sure that people have the care they require. And what I've noticed, often the folks who come from an internationally educated background, they come mid-career. So we have a lot of new and novice healthcare workers coming into our healthcare facilities now, so new graduates under 5 years. But someone who comes to us from a different province or from a different country often is mid-career. And so they actually come with a number of years of experience and actually become, some of the mentors in our system. Because we've seen so many retirements, if you look, a number of people came into the health. When I graduated from nursing, there was no jobs. So the majority of my nursing class actually went to the States in order to work. And so someone my age is a little bit rarer to see in the healthcare system. And so we've seen a number of folks retire. And so we have a lot of novice clinicians. And so for me, in my role as a nurse and as the health minister and as the MLA, those internationally educated folks who come really do bring a number of years of experience and actually can kind of help fill that, experience gap, not necessarily knowledge gap. So I think it's a really important part of us, reshaping and staffing our healthcare system.
And would you also see the continuing care CCAs within that ecosystem, or people who might be coming and taking care, working at large, or, so health is a larger, not just a clinician. How would you kind of see that?
Absolutely. I think, the other thing that we're working really hard at in health across the province is to increase representation in the healthcare system. So our workforce should reflect our communities. And so, it's really important that we see people with different ethnic backgrounds, different skin tones, all of those different things that maybe seem different, but they actually are so comforting and so reassuring to us when we go to the health healthcare system. So, it's part of a health equity framework is to increase representation. I also think it's really culturally significant in a time of crisis if you seek healthcare, and to actually have a healthcare individual who understands your, cultural background, but sometimes how essential it is to be able to communicate in your first language. At a time of real stress and strife, somebody who shares so many commonalities with you. So, immigration is a key part of our healthcare system expansion, from continuing care assistants, from physicians, nurses. We're working, as an example, with the Shapiro Foundation and the Pharmacy Association in Nova Scotia, bringing folks from refugee camps in Jordan to work as pharmacists in Nova Scotia. So
the
it's
EMBB program.
It's very broad in terms of how we are and who we are recruiting. And so, yes, there's population boom that's associated with that. The numbers of people that we can recruit has been reduced federally, but we really are targeting the folks who work in healthcare and also skilled trades.
Fantastic. Thank you.
Yeah, that's good. Here's my quick math. If you have one family doctor immigrating here and they have 1,000 patients, that's 1 to 1,000. They can do 1,000 more individual immigrants coming. Imagine you had 100 immigrant doctors that showed up. You would solve the family doctor crisis. And there you go. So in that sense, immigration is the key.
Hang on. Sorry. It's not a mathematics.
Of course not. I was trying to make it as simple as possible.
But I think what happens is that when people from other backgrounds come, and it's not just from the global south, even from global north.
Sure.
They also bring their culture. They also bring their families. They also bring their food.
Thank
so
gosh for that.
The social side of things are often not paid as much attention as the transactional side of things. And I think that's what I think, we in our community, we are very lucky and fortunate to have that sense of belonging, collective belonging, and how do we keep paying attention to that? So I think
I like your culinary-based recruitment. So and they're just saying, if you come from a culture that has very good food, we definitely will.
The Italians,
the
Ethiopians.
That's it. You didn't put Indian food at the top of your list.
I was not trying to be biased.
Sorry, Michelle, I cut you off.
No, I was just going to say it. Also, we see, folks who've come and moved to Nova Scotia and are working actually recruit friends and family members. And so sometimes, if we're very intentional and we work with the clinicians who've moved here, we can actually build communities, right? And so communities within communities, and we just thrive. So, we're really, we have more work to do, but we're really looking forward to having more people come from all different parts of the world. And it just enriches us. And great ideas from other places, right? We can't just be... And food. And food.
And dance.
And
so I think we have to wrap it up. But Michelle, we're going to give you the last word. So you are talking directly to the people of Antigonish. Is there anything... We haven't talked about a ton of things, but is there something you want to single out as your one message, something you wish you had talked about?
At the end of this episode.
At the end of this episode that you really want people to know about you or the government's position on something or healthcare, anything?
I want people to know that I'm here to the best of my ability to help, and I can't fix everything is what and sometimes no is an answer, even though we don't like the answer. But, my commitment is that we'll work hard. And if there's a place for government in some of the situations that people are experiencing, we want to help navigate that. So if you have a concern, certainly feel free to come by the office or call the office. And if you just a quick Google search, you can find us. And it is a privilege for me to be able to represent Antigonish, to sit in the legislature, and I don't take it lightly. It will be, the pinnacle of my career and lifetime to be able to have this job, and I'm very grateful for it. And
such a pleasure to have you, Michelle.
Thank you.
Yeah, this is the longest episode for sure. I'm not cutting any of this. This is all important. That's how important you are.
and your words and your thoughts and I think your reflections are really helpful.
Yeah.
Thank you.
And hopefully we'll have you back.
Yes. Thank you very much.
Thanks. Bye-bye.
Bye.
Thank you for listening to Let's Talk Antigonish. If you like the podcast, don't hesitate to subscribe. Just go to letstalkantigonish.ca and click. Voila! You'll receive new episodes right in your email inbox.
This podcast is a labor of love. Please consider making a contribution, small or large, maybe a monthly subscription. Depending on the level of public support, we would like to engage local producers and journalists to create more regular deep dive news stories about life here in Antigonish.
Right now, it's just Anuj and I doing this in our free time. You can read all about the podcast and ways to support us at letstalkantigonish.ca. And if you're a local business that wants to sponsor the podcast or even place an audio ad, we are certainly not opposed. A huge thank you to all of our subscribers and especially our paid subscribers, which have helped us to buy the audio equipment that we needed to get this thing off the ground. And remember to get in touch with us if you have an idea for a future episode or a burning question about life in Antigonish that you want us to explore and get answers to. We welcome all feedback. Just email us at letstalkantigonish@gmail.com. Let's talk, Antigonish.